Okay, I don't have disclosures, but a disclaimer, we're gonna have a lot of echo. I hope you like echo on this. Okay, so I'm talking about the RV, acute RV failure. I hope you guys realize that those four RVs are all gonna be read as hypokinetic on echo. We'll have similar echo reports. However, they are completely four different syndromes, and I'll tell you why at the end. So acute right ventricular failure is defined as a cardiogenic shock, predominantly caused by an RV problem rather than an LV problem or a valvular problem. It causes the same problems that the cardiogenic shock causes, so you're going to have congestion as well as perfusion problems. The key words in acute RV failure are so a subtle spiraling syndrome, and then another key is the need for an early detection to prevent the spiraling syndrome from taking place. So what do I mean by spiraling syndrome? There are four events that's going to happen when an acute RV failure ensues that's going to make the double hit problem, which is the increase in CVP is going to increase the congestion in organs, which will make the perfusion problem even double. The TR, which is going to start as a secondary TR but will end up as a primary TR at the end when the annulus dilates. The geometric changes in the right ventricle, and by that I mean the globular change in shape as well as that septal shift. And then eventually the drop-in map, which will cause coronary perfusion problems and ischemia. Okay, so what happens? Okay, good. So when I see an acute RV failure case, the way I divide it in my head is, first of all, I classify it pathophysiologically. Is this more of a preload problem, contractility problem, or afterload problem, right? So usually you have a combination of all the three, but you have a predominant problem. Two is the temporalistic approach, which is this an acute RV, or an acute and chronic homeometric RV, or a late burned out RV. So an acute RV will respond just by dilating, right? Just a change in the dimensions. While an acute and chronic RV will respond by hypertrophying and by changes in geometry, eventually. The third is the etiologic classification, and to think what is the likely etiology of this. So you have a couple of intrinsic problems like ischemia, acute ARVD, right ventricular dysplasia syndrome, and then you have a couple of setting etiologic factors like post-cardiotomy, post-LVAD, post-ARDS, etc. Okay, this slide trying to differentiate the acute from chronic, where you have a different response. As I said, the acute response would be just a dilating, so the RV will dilate, and then your RVPA coupling will be reduced, right? While if you have a chronic RV, it will hypertrophy and then eventually fails, and you will have a preserved RVPA coupling because of hypertrophy and preserved stroke volume. So what are the tools we have to detect acute RV failure and to manage acute RV failure? There is no surprise that it's mainly echo, echo, echo. Okay, for all the three classifications, you need echo first. And then a PA catheter for the passive physiologic approach. You might need a CT or MRI, otherwise for the temporalistic and etiologic understanding or classification. So when it comes to echo, some parameters that are very important will be a TAPSE, a tissue Doppler of the annulus, of the lateral annulus, fractional change, area change, a strain. A strain is good if you have a good quality echo and a good definition of the borders. And then you can do some coupling measures, which is a TAPSE to RV speed, if you could. And then PA catheter, you're going to have to calculate your PAPI, right? The pulse pressure divided by the CVP, as well as the ratio between the right atrial to left atrial pressures. Okay, this is a quick case with the echoes that I want to show that I saw a couple of months ago. So a very sick patient who had severe aortic stenosis, AVR for severe aortic stenosis. He wasn't a TAVI candidate for anatomic contraindications. As you can see, he had a really rough course post-op. And then when I took over, it was after 2 weeks, the guy was in low cardiac output syndrome, they couldn't wean inotropes, and he was congested like hell, and was going back and forth on BiPAP for hypercarbic failure. So, when you have this syndrome after 2 weeks, the best is to start with a clean echo. So, I didn't hate his RV function when I started with the Persona long axis. The prosthesis is okay. And then I saw a lot of TR that I didn't like. There was a lot of TR in this case. Moving to the apical 4, again, there is TR in there, and I didn't like the septal motion, so there is some deviation to the left. RVSP was calculated 37 plus CVP, so like moderate. And the S prime was somewhat preserved, 10. There was some pericardial effusion, and someone decided to do mitral flow variation, and there was actually pulsus paradoxus, but they forgot that that can happen with RV failure as well as with tamponade. So this was for sure an RV failure. You can see here the septal shift with diastole as well as with inspiration that confirmed to me the problem. The problem, and the IVC was distended and non-collapsible. So it was clear that this was mostly a preload problem. This guy is severely overloaded and his RV is suffering because of a preload problem. So switched to milrinone because he had chronic AFib and fast heart rate, kept the digoxin, avoided beta blockers, aggressive diuresis with Lasix. He didn't need CRRT. After 5 days, when he was minus 15 liter, milrinone was finally weaned off, and we started a small dose spironolactone and metoprolol, and he was shifted to the front. So an easy case, and it's mostly a preload problem that you will see in CVICU and in general ICU sometimes. So it's very important to remember that RV is not LV, so the pressure volume loop is different. RV does not have an isovolumetric relaxations or contractions. Okay, it's a triangular shape. The French-Starling curve, more importantly, is very different. The RV, if you fill it so much, the stroke volume starts to fail, right? So you will need the shift back, the septum to shift back, and the TR to decrease to restore the function. The interdependence physiology is very important. So a healthy septum moving toward the RV, not the LV, is important for both. So don't forget, the septum contributes to both functions, the LV function as well as the RV function. A healthy number, systolic difference, will be a 100 millimeter mercury. So the LVSP will be 100 millimeter mercury higher than an RVSP. So if that relationship is distorted, like you will see down there, so by an increased RVSP, then the septum will shift to the left, or rarely by decreasing the LVESP. When does that happen? With LVADs. When we have a heart rate free LVAD and we flow too high, then the septum will shift and you will have this echo. So you will have septal shift and what we call a suction event, right? Suction event, and that's related to a very high flow on the LVAD side. So what you need to do in this case, just drop the LVAD flow and the septum will go back, and then the RV function will be restored. Much easier than what we think. The RV and lung physiology is very important. As you guys know, the best PVR is usually at FRC, functional residual capacity. It's like us now, sitting here, we have the best PVR because we're not intubated and ventilated. Whenever you ventilate your patients, remember that you can go in the two pathways. You can de-recruit your lungs and lose a lot of volume, and then your PVR will increase exponentially, or you can keep increasing your PEEP, which is more forgiving, but if you go too much, then you will have an increased PVR as well. Okay, invasive versus non-invasive monitoring. When I have a complex RV cardiac shock, I need a PA catheter. That's the answer. And we have a very strong evidence to support that. In the case I showed you, I didn't need a PA catheter because echo was enough to tell me that this is a preload problem. When you have a complex case where you have an afterload problem, contractility problem, and preload problem, you need a PA catheter, as well as before MCS. If you are contemplating MCS and you have time, you better put a PA catheter, and I'll tell you why. So I'm gonna probably, for the sake of time, skip this case. So management-wise, so preload, what can we do to restore RV function? Diuretics and renal replacement therapy. So remove fluids, right, until the septum goes back. Afterload, inodilators, dibutramine and milrinone, they will take care of contractility as well as afterload, right? But sometimes you need pulmonary vasodilators. Now, if your patient is ventilated, it could be inhaled, okay, INO or ibuprostenol. But sometimes you need systemic ibuprostenol if you have a primary pulmonary hypertension case. But remember, that can drop your MAP so much. So the challenge is your systemic blood pressure. Contractility depends on your MAP and resistance. You have to choose between inodilators, dibutramine and milrinone. If you have a soft MAP, you better go with epinephrine. So an inopressor. Epinephrine is the best inopressor you have. Okay, then some etiology, some management directed to etiology, like reperfusion, if you have an inferior infarct with RV infarct, lysis for PE, anticoagulation for PE as well, and surgery to correct congenital and valvular defects. MCS, I'm going to talk quickly about MCS. This is not an MCS lecture, but we'll go quick about it. You have 4 options, and I'll show you that in a minute. The most important thing about MCS is to go fast if you're going to do it. If you think your patient is a candidate and he's failing in front of your eyes, you better go fast, you don't delay it. Now, the eventual therapy is transplant. If you're on MCS and you fail to recover, there's nothing you can do. There's no durable RVAD that is good that I know. Those people don't do well if you put a permanent VAD on the right side. So transplant is the eventual therapy. So, but remember, if you have this case, if you have an RV that is just dilated and maintaining the geometry with a lot of TR and septal shift, the answer is just preload management. Just diuresis or CRRT until RV function is restored. Very important to remember that vasopressin is the best pressor for RV cases because it does not increase PVR as much as norepinephrine, and phenylephrine is the worst. Very important to remember that milrinone provides more money in the pocket when it comes to pulmonary vascular resistance compared to dobutamine. So you have 4 options for MCS. You have Impella RP, you have an RVAD, and Protect Do or VA ECMO. Now, it's very important to remember that the first 3 will deal with a primary RV problem, will not deal with the left side, the left ventricle, right? The RVAD and Protect Do, you will be able to provide an oxygenator. So if you have a lung problems, you'll be able to manage that. You can add an oxygenator to them. Impella, you cannot. So if you have hypoxemia, you cannot use Impella alone. However, the most important thing to remember is that if your PA catheter shows a high wedge pressure or a high PVR, remember, the only option is VA ECMO. If you try to treat that patient with one of the 3, you're going to fail. Because you're just going to fall high to the lungs, and you have a high PVR or high wedge pressure, you cannot fix that, right? So then you'll have to go on VA ECMO and just relieve the pressure in all chambers, okay? And the other way around is true. If you have an RV that looks very severely hypokinetic on echo, but on PA catheter the numbers are good, then you may as well just support the left side with an LVAD, and then your RV will do fine. So the numbers are fine. So I'm almost done. So the tips and tricks, keep the rhythm fast and sinus, okay? So you need fast sinus rhythm. Preload, remove until the TR and septum shrink. Keep the CVP 10 to 15. For the afterload, lower and lower more if the left atrial pressure is low, or otherwise lower your left atrial pressure. For contractility, vasopressin, vaso the map, up and pump it out with dobutamine or milrinone. MCS before it's too late. And then remember that LV, unless diastolic and suicidal means SAM, wants usually what the RV wants. Remember that the lungs optimal settings are usually the RV optimal settings. Don't let the kidneys confuse you. They will eventually follow through. So if the creatinine keeps going up, don't let that confuse you if echo shows that the patient is congested. Wean inotropes off after preload and afterload are optimized. Okay, so the last thing is to stop the inotropes after your preload and afterload are optimized. So the first case was a primary pulmonary hypertension on ECMO. She had a lung transplant and she survived. She left hospital. The second case was a long biovental for infective endocarditis with post cardiotomy, biventricular failure. She went to VA ECMO for a couple of days and then she weaned off successfully and survived. The third case there was a burned out RV from severe mitral stenosis and severe pulmonary hypertension. The patient died. The last case here was similar to the case I presented, was just a preload problem. We diuresed the hell out of him and then he improved and the patient survived. Thank you very much.